Well, thank you, Rui. Thank you for that introduction, which is really much more, it's interesting to me to reflect back on 33 years of corporate life, but really, I think all of my experience has been driven by my very early experience just after I left university, where I was a direct patient care provider in the field of dialysis. And I had the good fortune to be involved with a number of leading clinicians at the time. To 2050. Some of it, of course, is actual data. Some of it is projections. So we expect that the world population will continue to grow, and from the turn of the century to 2050, grow by about 90%. But that growth is not uniformly distributed around the world. And in fact, you can see that much of that growth is in Asia and Africa. And we see very little population growth in North America and in Western Europe, and even in South and Central America. What's driving that? Well, there are a number of factors. One is, and to me this is one of the great public health achievements of the last 100 years, is this dramatic reduction in infant mortality rates. And you see the trend is downward around the world, even in the least developed economies. And in case you're interested where Singapore is, you can see that mortality rates were already low and are down below the level of the most advanced economies worldwide. So we see a drop in infant mortality rate. More children are living into the 5th year of life. Along with that, we see a drop in fertility rates, the number of children per woman. And again, we see in all areas of the world, even the least developed countries, a significant drop in fertility, reflecting the probability that more children will live to maturity. And if we also think about the replacement level of 2.1 children per woman, you see that the advanced economies are and have been for some time and are projected to be below replacement rate. But even the least developed countries are coming down very close to replacement rate. That, however, is not uniformly distributed. Here's the picture of fertility in 1950. And you can see that on the spectrum here, this is down at 0.5, 1 child per mother, all the way up to 8. And you can see how that pattern is spread around the world. This is what it's projected to look like in 2050. So almost all of the world is expected to be at or below replacement levels. And the most significant gaps in that, of course, are Central Africa and Central Asia. Here's Singapore. So you can see that fertility rates were already dropping just at the time of independence and have continued to stay very low. Hence, all of the measures we see in the Straits Times, the celebration of Mother's Day, all of that, the promotion to try to bring the birth rate up. At the same time, so you have more children making it into the first decade of life, you also see a significant increase in life expectancy around the world again. And even for the least developed economies, we see almost a doubling in this 100-year period. And so someone who was born in a least developed economy and could expect to live only to age 35 60 years ago can now expect to live almost to 70 years old, and of course much higher in the more developed economies. But we see not uniformly spread around the world. Asia showing the most rapid rise in life expectancy, but we don't see that in Africa. Singapore, again. So you can see that the projection is that Singapore will be above the average for the most developed economies by a significant margin towards the end of the period. So what does that mean? It means that the populations are aging. More people are living longer. Fewer are coming in at the beginning. And so the median population, as shown in this chart, increases. And you can see here today where we are, significant upsweep, again, in all the regions of the world. Here's Singapore, and expected to be significantly above that of the advanced economies. Now shift slightly to look at the percentage of the population over age 65. Which in demographic terms is considered to be at the end of one's economic working life. We're seeing that changing, of course. And you see all of the economies are sweeping upward from today. And in fact, we're at a significant inflection point in all of the economic regions of the world, that all of these curves start to turn up significantly in the next few decades. Here's Singapore. So that turn actually happened back here not long after independence and has been going up steeply, but more steeply along with all the other economies about now. Again, we see worldwide that the concentration of elderly population in 2002 there, but also look at Western Europe, Japan. So think about what that means in the shift as Asia ages. Europe is already old and getting older. Now let's look at a little more detail on how the population is distributed across the age cohorts. On the horizontal axis, you have 5-year cohorts from 0 to 4 years, 5 to 9, and so on, all the way up to 100 years. And then you have the number of people in that cohort. And I've broken it down into 25-year trends here. So we see, starting in the earliest one, fairly small population, and you see infant mortality as the population drops off, and then slow attrition over the years. But with advances in public health and economic development, you see more coming in to the population each year. And it's only up to here where we stop seeing that early attrition with mortality. You also see down here, as people live longer, the tail of the curve starts to move to the right, to longer. So these are the least developed economies, fairly smooth progression. Here are the less developed, the middle income countries. And you see a similar phenomenon, but a little bit less smooth. And you also see in the 2050 picture a lot more people living and with very little mortality. Let's look at the advanced economies. A much more complex picture, so I'll simplify it and just look at what it's projected to be in 2050. Very little infant mortality, a lot of people living longer, and in fact you have the largest cohort in the population being in the 60 to 70-year-olds. So you end up with a generation of 40 and 50-year-olds looking after a generation of 60 and 70-year-olds. Again, you see the increase in longevity here. Here's Singapore's profile. A bit more complex. But you can also see the challenges that that may represent for the society. Here's the working age population, roughly in demographic terms from 15 to 65. So it's these people in here who are supporting, through taxes, through family, through other measures, the people in this cohort as well as in this cohort. So this is what demographers call the dependency ratio. The number, or the ratio between the number of people here and the young and the old. So if we look at the trend over this same 100-year period, you see in the more developed regions of the world, the blue, relatively flat, but right now at this inflection point starting to go up. And in the least developed regions, as you have fewer children because of dropping birth rates, lower fertility, you see actually a reduction in the dependency ratio. More people are living into the working period, but the bulge has not moved through to the elderly. And I'll just take one example. This is Japan, where it's very extreme. I could have also chosen Hong Kong or Macau or Portugal. But you see here, the child dependency ratio is very low. So just over 20 children per working adult. But you see the old age dependency ratio going up significantly. So driving up the combined dependency ratio. And just one manifestation of this, I saw in the business press recently that selling more adult diapers than child diapers. So for the first time, this manufacturer saw that. So it's a small sign of these demographic trends. What it also leads to, I think, is a change in the nature and the demand for medical technology. You've got this need to look after the elderly. And those people probably cannot be looked after in the same intensive ways of hospitals as they have been in the past. And where will the workers come from to provide that care? Japan already struggles with an inability to recruit enough nurses, especially in retirement in the lower intensity care settings. So you see, and this is from Japan's Ministry of Economy, Trade and Industry, result of a concerted government program to develop new technologies to aid in the care of an elderly population. This from The Economist last year, talking about Singapore, South Korea, and Hong Kong are aging faster than any other economies, if you look at the rate. And you can see, in terms of the numbers of workers per retirees, these three are coming down over the next decades to rates equivalent to those in Germany, Italy, and Japan. Here's Singapore's dependency ratio trend. And again, as elsewhere, a significant uptick. So this is why President Tan last week in St. Gallen was talking about the challenges faced by society in Singapore to look after the changing healthcare needs of the population. And what does that mean for society? Here's one example of the unmet demand, which is physicians. And I don't have Singapore here, but just looking at the variability around the world of the number of physicians to look after the population and the healthcare needs. And you see, at least, now let's look at the question of mortality. One of the endpoints in assessing the health of a population is death rates. And you can see that premature death is much higher in some parts of the world. I don't think this is any surprise. But let's look a little bit more closely at what's driving that. First is a change, and this is a slide from from World Health Organization, looking at the global burden of disease from 1990 to 2020. And you can see 25 years ago, infectious disease accounted for about half of the burden of disease. In this period, then you see a shift and the growth in percentage terms of non-communicable, non-infectious conditions going from about a quarter to almost half of the burden of disease, and infectious conditions being less than a quarter. If we break that down a little bit more, we see here, again, the global burden of disease in 2008, and that 60% roughly are non-communicable diseases. But if we look how that is spread across the income and development groupings around the world, you see that in lower middle, upper middle, and high income societies, non-communicable conditions account for most of the burden of disease. It's only in the lowest that you see the infectious conditions are the major burden. The probability of dying of a non-communicable condition, again, not uniformly spread around the world. So let's look in more detail at some of these non-communicable conditions. This is the geographic distribution of ischemic heart disease. You can see a very large concentration, especially in India. But you also see it in Europe, North America. Here's diabetes. Again, very large prevalence in Asia, especially South Asia. Not much incidence in Africa. I was really interested in, this is a study that came out very recently looking at the projected increase in the rates of diabetes in the populations in different parts of the world. 110% increase, 96% increase in Africa. 46% in Asia. So diabetes is likely to become a much more significant part of the burden of disease in Africa than it has historically been, at least in part due to people living longer, perhaps changes in diet, changes in exercise. But even more interesting from the standpoint of medical technology is this chart from the International Diabetes Federation. And the numbers in the center are the incidence of diabetes in a population. But the black semicircle around the edge is the percentage of diabetes cases that are undiagnosed. So worldwide, almost half of the cases are seen as undiagnosed. Why is that? Is it a failure in healthcare delivery systems and diagnostics? Is it a problem that the technology is not available, it's not affordable, or it's available in a country but it's not accessible, it can't be used? So clearly there's an opportunity here, system-wide, to think about making more technology available. Deaths from cancer, again, very large in Western Europe, Japan, North America, less so in other parts of the world. But if we look a little more closely, and this is a recent study done through the World Health Organization, and the red here is the mortality, and the blue is incidence in the less developed, medium developed, and most highly developed regions in the world. And it's interesting that the width of the red bar, the mortality is pretty much constant through all those economic regions. But look at the incidence. And we saw that in the previous chart with the map showing the concentrations in geographic areas of cancer. But these are a lot of cases resulting in this number of deaths. So clearly, more people as a percentage are surviving cancer in the more developed economies of the world than in the less developed parts of the world. So again, a question of why is that? Is it a question of system breakdown or lack of systems? Is it a question of access to diagnostic and therapeutic technologies? So as I've gone along, I've implied this thought from the Roman poet about the greatest wealth is health. I think intuitively, individually, we understand this. But let's look a little bit more closely at the relationship between economic development and health. And just one measure, this from the World Health Organization, of the economic costs of poor health. And this is WHO's estimate of income foregone in a 10-year period in these economies. And so you can see the BRICS nations especially stand out, of China, India, Russia, and Brazil. So huge economic effect of poor health, disability, shortened lives prematurely, the burden for looking after someone who has a disease, and these are all the non-communicable conditions. Now think about wealth in the world. Here's what the picture looked like in 1990. No great surprise here, I'm sure. Most of it concentrated in North America, Western Europe, and Japan. What's it likely to look like in 2015? No great surprise. Significant shift eastward to Asia. Unfortunately, not much change north to south. It's well known that it's been the low and middle income economies, the smaller economies, that have been growing most rapidly over the past decades. And you see here, in the developing countries, not only have they grown faster, but in fact were less affected by the economic downturn that affected North America and Western Europe. So that's led to this phenomenon, which is the share of the global economy between the developed and the less developed economies in the world. And it's projected, if these trends continue, and the evidence from last week when China was said, at least in purchasing parity terms, to have surpassed the economy of the United States, this trend is likely to continue, and we expect that sometime within the next 5 years that the so-called developing economies collectively will account for more than half of the world's economy. And what happens when a society gets richer? Well, individually and in our families, we tend to devote more of our disposable income to health and health care. And you see that here with rapid growth in Asia and Australasia, leading the world in spending on health care. At the level of societies, we also see that. This is data from the Organization for Economic Cooperation and Development with gross domestic product per capita here and healthcare spending per capita, and you see a nearly linear relationship between the two. So not only individually, but collectively as societies, as we become richer, we tend to spend more on health and healthcare. Healthcare spending in 2001, probably no great surprise where it's concentrated. Interestingly, if you look at Europe, 7% of the world's population, 25% of gross domestic product, but 50% of social cost. That's probably unsustainable, especially as Europe continues to grow very slowly economically. So huge economic challenge for Europe going forward. Aging population, slowing economic growth, and with high expectations set by social cost. Turn to Africa, though, and you get a different picture. 11% of the world's population, 24% of the global disease burden, but only 1% of global expenditure on health. So huge inequalities. One can speculate on the reasons for that, but a big challenge. Now, this is a recent study done by the consultancy Ernst & Young, trying to put some dollars to the expression, the greatest wealth is health. And they said if you could achieve a 10% reduction in heart disease mortality, that could result in an economic value of $3 trillion over the next decade. 1% reduction in cancer mortality, $400 billion. Or a 10% increase in lifespan, 4.5% of savings. As people have an expectation of living longer, of having to be more dependent on their savings. So if you see pressure on your Central Providential Fund, this is part of the reason for that. So now let's think a little bit about mortality. And as you think about the causes of death, it can be broken down into premature and mature. We can't really do too much about the end of a long life. Avoidable and unavoidable, and then preventable and those that are amenable or treatable in some way. And this, to me, is really the real promise of medical technology. This is where we work. It's can we diagnose and treat these preventable and amenable conditions. This is what the world looks like in terms of preventable deaths. Hugely concentrated in South Asia and Africa. But mortality is not the only consideration. And to me, this is the other benefit of medical technology. It's really a question of disability. What percentage of a person's lifetime is spent living with some disability, some significant disability that prevents a person from living independently, from working if they're of working age? We know that as a society ages, healthcare spending goes up. And this chart has age cohorts from 0 to 4. So these are the same ones I used earlier in the demographic pictures. And then spending as a percentage of GDP per capita. And no great surprise, but it's interesting to see the magnitude of the increased spending in societies. And these OECD members are the 30 advanced industrialized economies in the world. And so you see more healthcare spending in the last years of life. So in terms of cost savings and in terms of quality of life, can we reduce that period of disability, that period of needing more intensive healthcare to a shorter period of life? And just another example, looking at the costs of this again is OECD data, and looking at the costs of long-term care. And the little green triangles here that you may have a hard time seeing are what they expect to spend in 2050 on long-term care. And Sweden and the Netherlands here expects to spend over 8% of all of its economic activity on long-term care. So what can be done to reduce that? Because think about this in terms of transfers of wealth from the working generation, the younger generations, to older generations. So what does that mean for social tensions? This has led to some work, and here I'm using a chart from the University of Groningen in the Netherlands. Their minds have been concentrated on this problem, to what they call successful aging, healthy aging. And so they're thinking about what they call the health span, but the lifespan here, and then the fitness, just your general state of health, your ability to look after yourself, your level of vitality, and saying, really the challenge is to compress that period of disability into a shorter period at the end of life. It's not so much a challenge of lengthening life. It's more how to compress that period of morbidity to the end of life. Another trend. This is the trend in uptakes in mobile telephones. And you can see that we're almost to the point where there are as many cell phone subscriptions as there are people in the world. They're not universally or uniformly distributed, but the fact is that mobile telephony is now so ubiquitous. Are there opportunities to use that to address some of these health questions? I'll take the one example of diabetes. 80%, 85% in this estimate of cases in sub-Saharan Africa are undiagnosed and therefore not treated or not properly treated. Here's an example of a device that uses a mobile telephone with a small portable blood glucose meter to measure the patient's blood glucose level and then transmit that data by mobile telephone to a clinic nurse or physician who can then monitor the patient and advise them on their treatment. That helps in many ways, but one is the patient does not have to leave their home and travel for a day or half a day to a clinic to be seen to have their blood glucose tested. So what does that mean in terms of the ability to look after the family, the economic activity, the ability to manage the farm? This is another device that uses just a simple cardboard chip that's sensitive to glucose in urine. And the user puts a drop on the card and then takes a picture with their cell phone camera, transmits it by cell phone where it's red. Again, can be used in diagnosis and monitoring. So you have a network technology that wasn't intended for this purpose. It's now being adapted for these remote care technologies. Now I could go on with lots of other examples, and I think all of you involved in the field can think of examples of for yourself. But to me, this is a very interesting example of how the new technologies can address these public health trends. This is showing internet use. And about 40% of the world's population now has access to the internet. So are there medical technologies that would allow us to provide better care and diagnosis of patients using internet-based technologies? So now, back to health and wealth. This is a chart done by Dr. Hans Rosling. He used to be at the University of Uppsala in Sweden. Again, drawing the relationship between money in terms of gross domestic product per capita in US dollars versus health, and using life expectancy as a proxy. And here's where, in 2010, the world's economies lined up. in that orientation. And the size of the bubble is proportional to the size of the population. So no surprise here, India and China are the largest bubbles. Singapore would be in some little bubble way up there. No great surprise here, but this shows very clearly the relationship between health and wealth. If you look at the colors, these correspond to the regions. Blue is Africa, sub-Saharan Africa. So you can see that with the exception of Afghanistan down here, shortest lifespans and least economic development is in sub-Saharan Africa. But this is not static. And in fact, Professor Rosling has a very interesting animation of this chart, which goes back to 1830 or something, showing how these societies have moved over time. And so it's the old expression, demography is not destiny. There's an opportunity here to think about public policy, that as a society gets richer, how much of that wealth is devoted to health and health care. But if you also think about it, think about the healthcare needs up here in this corner or down in this corner and in the middle. And as we've seen, we have a lot of aging populations up here. We have economies here that have a dual burden of disease, of infectious conditions still being a significant part of their burden of disease, but with growing prevalence of non-communicable chronic conditions. And certainly that's the case in the middle economies. So think about what technologies are needed where and how does that differ? And then a key question, and I don't think anyone knows the answer to this, is the ability to pay. Ability to pay for these technologies. So this is leading to more and more debate at the World Health Organization and elsewhere about what are called the 4 A's. Availability. So does a technology exist? And if it exists, is it accessible to those who can most benefit from it, who can most need it? And then is it appropriate? Well, it doesn't really help if you have an ECG machine that depends on a reliable supply of electricity, but the small rural clinics in India don't have reliable electricity, or clean water, or clean medical gases, or trained staff who can use them. And then is it affordable? So I think much of the debate about medical technology at the policy level will be about these 4 A's. So for those in industry, what does this tell us about the direction to drive? And what will industry be challenged with? And what opportunities will exist for innovators? Another study in the Global Forum, 97% spent by high-income countries was used to develop healthcare products, processes, technologies for use in their own market. So only 3% available for the rest of the world. And the focus has historically been on developing high technology solutions for use in those domestic markets. Will that still be necessary and appropriate in future? Another example, and you can read the statistics here, 13% of the population consumes 76% of global medical technology use. BRICS plus Indonesia and Pakistan, 50% of the world population, but only 4 to 5% of medical devices use. So clearly there's a lot of unmet need. And where will that new technology come from? This is a study done by PwC, the consultancy, and they looked at, and this was mostly based on interviews, they looked at the value created by new innovation in the field of medical technology. And it's their view that 50% of the new technologies for medical devices will come, it will be not only radical and disruptive, but it will also come from new entrants in the market. It will not be by the incumbents, although there will be some overlap, but really it will be through new entrants. Today, most of the global medical technology industry is based in the United States, Western Europe, Israel. I submit 15, 20 years from now, it will be much more broadly dispersed. And we'll see a change in the nature of this technology, shown here by The Economist a couple of years ago, to go from mega-med technology suitable for North America to something more economical, appropriate to the settings. And some of those examples could be this neonatal incubator. And the source of heat? Automobile headlamps. And most of the components are car components. Why is that? Because automobiles are widespread, repair parts are ubiquitous, and they're low technology. You can service them readily. Here's one, maybe even lower technology, using bicycle frame as a centrifuge for clinical laboratory. We also see a growth in technologies for this aging population. Maybe considered low technology, but it's no less necessary. In fact, from the trends I showed earlier, it's become even more necessary. But you still have the problem of accessibility. And so technology, I submit, is not only individual discrete devices or even network devices, but it's a broader question of business process, of government, of systems. What's required to get a technology to the person who can most benefit from it? This is an example from vaccines, but there are many others for medical devices. So Peter Loscher, who was the former CEO of Siemens, a German manufacturer, talked about what he called smart products. They'd be simple, maintenance-friendly, affordable, reliable, and timely to market. And driven by a scarcity of resources, not only for the consumers, but also the users. So he and others have introduced the concept of frugal innovation. And I think that will be one of the defining trends for medical technology in the future. So, I've thrown out a lot of data. I painted a lot of pictures. Let me see if I can pull this together into a thesis. So, worldwide demographic, public health, and socioeconomic trends will create technologies for policymakers in healthcare. Affordability, sustainability, transfers of wealth from one generation to another, healthcare resources, infrastructure, where is care delivered, regulatory capacity. All of these new technologies still have to meet our social expectation that they're safe, they perform as intended, and of reasonable quality. And then how to redress this imbalance between North and South, rich and poor. I've outlined the aging populations, the shift from communicable to non-communicable diseases, a shift to less intensive care settings. How much of care will be delivered in tertiary care academic teaching hospitals as compared to regional district clinics? We also see rising prosperity, and as I said, more people tend to spend that prosperity on health, but it also brings with it rising expectations. One of the key expectations of government will be the provision of health and health care. So what tensions will that create in societies? I would say that the internet has also led to that increase in public awareness. The internet has exposed more people to what's available in other parts of the world. I submit unmet clinical need or imperfectly met clinical need will continue to drive this innovation, and it will be driven by the desire for healthy aging and frugal innovation. And those new technologies will have to be robust, They'll be intended for use in less controlled environments, possibly have fewer features to make them simpler to use, or smarter features. They'll have to be supported by lower trained personnel. You can't necessarily call the service technician from Germany to come to the hospital in India. So going back to this picture, think about the technologies that will be needed in the future for these different subsets of the world's population. The aging population, the dual burden of disease, the chronic conditions. So we'll see, I think, a demand for technologies that are the high-tech intense treatment, those for chronic care at the end of life, and then those for use in resource poor societies. And where will they come from? And that, to me, is really the exciting challenge for SSB. I'll carry on to go to another subject Rui asked me to talk about, which is regulation. And that's really, again, this subject of how do we assure that the products that are made available are safe and perform as intended and are safe? I submit to you that access to these technologies is an important measure of social progress in all economies around the world. And as citizens, we expect that regulation, and this is my thesis, that enlightened, appropriate, judiciously applied regulation of healthcare goods is a public good. And yes, at times it is burdensome, especially for those in industry, but ultimately it should be seen as a public good. Protection and promotion of public health, good governance, it meets the expectations of citizens. It also, I think, benefits industry because it contributes to public confidence in the products that are sold by industry. Regulators are on the critical path. I don't mean the choke point, but we all know that before you, in most economies, the advanced economies, before you can place a medical technology on the market, you have to go through the regulatory process to show that it conforms with the legal requirements. And it's the effectiveness and the efficiency with which the regulator performs that essential task that I think we can always challenge ourselves to do better. And we should recognize that the regulator, through their practices and their requirements, determine the ability to bring these new technologies to market. We've talked about the 4As. So what's happening worldwide? Well, we see in our sector, in the medicines and biologics sector, and in other sectors as well, a growing convergence amongst regulatory requirements and practices, a progressive narrowing of differences. So convergence is really to eliminate those differences between regulatory requirements and practices over time. But we still have the question of accountability. A regulator ultimately is accountable to the Parliament, and the Parliament ultimately to the people in the democratic countries around the world. So much of the legitimacy of regulation goes back to the question of accountability, and it goes to the question of political sovereignty. There is no world government. We're all governed by individual national governments. So how do we regulate efficiently? How do we address the question of political accountability? How do we respect the national obligation to protect health and safety, but at the same time take advantage of the practices of other authorities in other parts of the world? And that, to me, is one of the values and benefits of harmonization, regulatory convergence. I've outlined here a number of the reasons. I won't go into all of them in detail. One of them is pooling of expertise, and I think just bringing people together in the same room allows sharing of expertise. It also obviously protects and should protect public health, both directly in-country market, but by that raising of competence in other markets, which is especially important for regulators in primarily import markets. But I submit it also should promote investment and innovation, and I'll come back to this point in a minute, and facilitate international trade. Regulation does not exist in a vacuum. So, back to my earlier point. In my view, unmet or imperfectly met clinical needs drives innovation. If we think about the product life cycle of medical devices, it could look like this. This comes from a global harmonization task force, starting with a concept, product realization, placing on the market, use, end of product life. A cycle like this. But you note that it's a closed cycle. So this end of product life feeds into the next cycle. What drives that? Well, I would submit it's several factors. First, it's that unmet clinical need. Someone, somewhere, has to have an idea about how to address that clinical need. A good idea. And typically, in the medical technology field, as compared to, say, the medicines field, that comes from the clinicians. That has to, in turn, attract financial capital. Money has to come from somewhere. And that capital is some form of asset that can be used to create other assets of value. And that, in turn, attracts intellectual capital, the knowledge, the know-how of an educated workforce to turn that idea into a practical product, to go from laboratory workbench to bedside. I used the term intellectual capital, not intellectual property, because it's a much broader concept than just intellectual property. It's not only patents and trademarks. And if this works, it creates more value and leads to more ideas, and we create a cycle like that. But what drives that cycle? Well, first, like it or not, someone somewhere has to get a return on that investment. For them to be willing to devote some money at risk to this technology. And remember that medical technology is competing for investment with other sectors. You could invest your money in video games or the next Facebook, or you could invest it in medical technology. And one of the drivers is return on investment. So what drives that? Well, the clinical adoption, the commercial success obviously is a key point. Another one is the risks and costs in any return on investment. And typically, you expect a higher return if there are greater risks. And included in the costs are not only the risks of the technology and the clinical science, but also regulation. How predictable, how transparent is that regulatory process? And that's determined by favorable government policies. Do we create a favorable ecosystem for investment? And to me, Singapore is a classic example of joined-up government policy making to create that ecosystem in support of investment in medical technology innovation. So, if we have these two cycles, I think of them more like a set of gears that one drives the other. The cycle of investment and innovation on the one hand, driving the product life cycle on the other. Let's look a little more closely at the product life cycle and think about the pre-market stage and the post-market, which in a way are arbitrary divisions, but are still, I think, relevant in framing the regulatory framework. Think about the costs of compliance for the innovator, for the manufacturer. So can you spread those costs of compliance over more markets? So I've tried to simplify this with this simple matrix here. On this axis, we have incremental sales revenue. How much more money can the innovator make by going into another market? And on this side are the incremental costs of compliance. So beyond the costs of compliance in your home market. Well, you think about it, it's a probably attractive investment to bring a product into a market if the incremental sales costs are low or compliance costs are low, even though the sales revenue is low. Similarly, where your high incremental costs are matched by high incremental sales. And obviously, where you have low incremental compliance costs and high additional sales. But obviously, in this quadrant, that's not going to be a very attractive investment, where it costs you a lot more to get into it, but you're not going to make much more revenue from it. And remember, this is all driven by how do we come up with affordable and appropriate technologies for less developed economies. So in my view, regulatory convergence, harmonization, can help drive the creation of more attractive markets. As an innovator thinks about moving into more and more markets, they become, by definition, smaller. The reward is smaller. So to the extent that their requirements are not harmonized, it makes it an increasingly less attractive market. And does that help bring the public health benefits to more people and more societies by shifting further down in this direction in the matrix? Today, about 85 countries out of the World Health Organization's 194 regulate medical devices to some degree. It can be minimal controls, or it can be very elaborate, complex controls. Every year we see more countries headed down that path. So what regulatory model will they turn? Would it be that in the United States, which is inherently the most costly, most complex model, or is it some alternative? So, turn now to the Global Harmonization Task Force, which many of you will have heard about, GHTF, which is really what I think of as the rootstock. It's the intellectual foundation of regulatory convergence in the medical technology sector. Began in 1992, a joint voluntary platform of regulators and industry from Australia, Canada, Europe, United States, and Japan. 5 study groups and a steering committee where all the work was done. That process, that forum ended in 2011-12. Over the years, it led to the development of what's called the GHTF regulatory model, which is an umbrella that essentially shows how the 51 GHTF guidance documents fit together to create a comprehensive framework for regulation, regardless of the class or the complexity or the risk of a device, regardless of where in the world it's manufactured. How do you have a harmonized set of consensus, best practices, and best requirements for medical devices? It's built upon a stair-step approach using basic foundational controls for those with the fewest resources, then a set of medium controls, and only for those who have the most resources and have the other supporting framework, the highest set of controls. Over the years, GHTF has spawned and has been the intellectual foundation for other harmonization forums. The Asian Harmonization Working Party, which is a bit of a misnomer because it now has membership from South Africa, the Middle East, South Asia, and South and Central America. But it's another forum for those economies that have less developed and emerging regulatory systems. APEC, the Asia Pacific Economic Cooperation, which is essentially the large Pacific Rim economies, also has a harmonization forum recognizing this is important not only for health but for trade. And then the World Health Organization has issued guidance on medical devices regulation for its 194 member states based upon GHTF guidance. ASEAN, here in this region, is very close to adopting, and we expect it will enter into force in 2015, the ASEAN Medical Devices Directive, based very closely on GHTF guidance and based very closely on the Singapore and Malaysia medical device regulations, which are the national implementation of many of the GHTF guidance documents. That's been supplanted now by the IMDRF, the International Medical Device Regulators Forum. And I won't go into that in detail, but it's a regulators-only forum. It's broader geographic representation in that it now includes the BRICS along with the GHTF founding members. So as we think about harmonization, can we describe what success of regulatory convergence would look like? And I tried to explain this at a meeting of the Institute of Medicine in Washington, D.C. a couple of years ago. I came up with this scheme of, on this axis, comprehensiveness. In other words, how many parts of the medical device life cycle are covered by regulation? And on this hand, what's the degree, extent of harmonization on GHTF guidance? And we could put various countries on this matrix, and I do this with some hesitation at the risk of offending someone somewhere. But the trend is this way, to move left to right. Regulation tends to move that way. It only becomes more complex, not less. Here's where I would suggest at one point in time many of these countries would fall out in this matrix. It's purely subjective. It can't be measured readily, but something like this. From those who have essentially no regulation to those that have very advanced regulation and they're highly harmonized. But the trend is generally like this, to promote convergence on that GHTF regulatory model. Unfortunately, as GHTF no longer exists, there's the question of how will this be maintained and by whom. But, as I've said, that forms the foundation for APEC, AHWP, and ASEAN. So, and you think about the number of people around the world represented by those groupings. Through these initiatives, we've now moved in the direction of convergence amongst regulators for probably 75% of the world's population. Beyond that, will there be an IMDRF regulatory model? Perhaps. Will we end up with a future that looks something like this, where you have some economies that have basic GHTF controls using that stair-step model, some that have full GHTF controls, and then perhaps a small group that have GHTF plus IMDRF? So, but really, going back to where I began, this is all about people. So can regulatory convergence promote further innovation of medical technology that will be affordable, available, and appropriate in the context of its users? There. And will regulation, ideally harmonized regulation, assure that those products are safe, they perform as intended, and are of high quality? And will that contribute to measurable health gains? I've outlined the health challenges. Can harmonization of regulation as an enabler, as an encouragement for innovation, help us address those public health needs? So I realize I've covered a lot of ground. You've been very patient. I've shown you a lot of data. I'd welcome your questions.